Next, we have Dr. Eddie Wasser. Dr. Eddie Wasser has more than 30 years experience in emergency medicine and pre-hospital care. He holds staff privileges at two University of Toronto teaching hospitals and a lead physician at the Cleveland Clinic in preventative and executive medicine. He has a Harvard Fellowship Certificate in disaster medicine, executive healthcare, and dignitary protective medicine. Dr. Wasser is the Chief Medical Officer for Pearson International Airport and the Medical Director for Ontario Lotteries and Gaming Corporation, Canada's Wonderland, and many more. He has a master's degree in counterterrorism and has been the Medical Director for the Prime Minister's Protection Detail of the RCMP for the last 21 years, and the National Director for, the National Director for the RCMP's Emergency Medical Response Program, and was the pillar lead for the critical incident response for the 2018 G Summit in Quebec City. He's a co-author on the chapter on protective and VIP medicine with two White House physicians in travel medicine. We're happy to have Dr. Wasser join us today, and we're looking forward to have him address some of the concerns the construction industry has around vaccines. Thank you, Dr. Wasser, for joining us, and the floor is yours.
Thank you, Amit, for inviting me. Thank you, Andrew, for inviting me. Now I get to see a face with a person. And Mike, I came in late, but I always enjoy, like Anima said, hearing you speak. I'm going to try and share my screen. Hopefully it works. Technology often doesn't like me. Let's see if we can make this work today. Where is my presentation? It's not coming up. Advanced files. Why is it not coming up?
If you open your presentation on your computer, then it pops up a little quicker sometimes, at least for me.
There we go. So
I know I have too many windows open too, so.
So let me try that again. Share screen. There it is. Yep, there we go. And we're just gonna go right up to the top here. And look at that. Love when something works. Okay, can everybody see my presentation?
Yes, it's up.
Yeah.
I'm just going to minimize this. Okay. All right. Thank you for that very kind introduction. My name is Eddie Wasser, and thank you for inviting me to speak on vaccines. I've done a lot of work in the area of COVID regarding my corporate clients, collaboratively with a number of institutions, and doing a lot of work in vaccine, and happy to answer any questions. I thank you, Andrew, for sharing the survey in advance, because it allowed me to have some insight, but also reassure me that I'm hitting on some of the salient issues that some of your membership or who have some hesitancy in vaccines will hopefully get over that. I believe a physician's job is not only to provide good medical care. Our job is very much education, and there's been a lot of misinformation, unfortunately, in the world of vaccines. I'm highly critical of the media and how they've handled this, and I think that's created a lot of angst and anxiety amongst many people, and hopefully I'll help allay some of those fears today. Let's start off by talking about just vaccines in general. Vaccines, they're recognized by the body as foreign. And that's a good thing, because if you had a splinter, your body would recognize it as foreign. And if you couldn't get it out, eventually it'll create a blister, isolate it, and so on. That's exactly what happens with a virus as well. Your body recognizes a virus as being foreign, and it activates its own immune system and will attack it. And that's exactly what vaccines are doing. Vaccines are basically tickling your immune system, alerting it that something is unusual, and let's address it. So allowing your own body to do its own work, using antibodies and lymphocytes, which are a component of your white cells. I don't know if you can see my mouse pointing to the kind of the crown, the coronavirus, little spiky things that we know that are in coronavirus. And that's what our immune system is being taught to recognize when we're given a vaccine. In Canada, there are basically, now it's not allowing me to advance my slide. Now, why is that? There we go. Whoops, there we go. In Canada, we have two approved vaccines that involve virus and two that do not. So the AstraZeneca and the J&J vaccines are both approved, and nobody has ever gotten any J&J vaccine.
Sorry, I don't think it's not switching. I'm still seeing the same slide.
We're actually looking at your
the first
not the
one.
Presentation mode, but
okay. So thank you for letting me know. Share is paused because your shared window to the front. Resume share. Let me try that.
If you go to the
Share.
slideshow tab,
Yep. I apologize, guys. Stop share, and we're going to go back to share. And are you seeing
Yep.
it?
That's done it. Yeah.
yeah,
Okay, so but for some reason, it's not letting me go up to the previous slide because this is not the slide that I wanted to look at the other slide first. As I said, technology does not always like me.
Try the left, the direction arrow on your pad. Try the left one there. That makes sense.
Yeah. it's
Or
not
I
letting
think,
me-
okay. Do
it's
you want me
not-
to try and share it and you can tell me next slide?
Yeah, why don't we do that, Andrew? I
Okay.
sent Andrew a presentation just in case something like this were to happen. So I'm gonna just shut that down and allow you to go back and let Andrew open the presentation. And I'll good old fashioned way, I'll have to say next slide, please. I apologize to the audience.
Okay, and I just got to share mine.
Mhm.
You know what? Your PowerPoint doesn't like me either. It's using all my bandwidth here. Let me see what I can do. I'm sure I'll be able to figure this out though. Maybe I won't. Jeez. Can you guys hear me now? My computer's frozen.
We can hear you.
Okay. Well, that's not a great sign. So maybe you can continue with your deck and we'll see if I can catch up with the visuals.
Oh, you mean just open up my deck as if I'm talking
Yeah,
to it?
just pretend like we can see it.
Okay, which is really unfortunate because
I'm going to send it to you, Amina, to see if it works better for you, okay?
sure, yeah, no problem.
yeah. So I'm going to go. So the next slide was AstraZeneca and J&J. And basically AstraZeneca uses a harmless, and J&J, a harmless altered version of the common cold virus, which is called the adenovirus. And the important thing about this is that the previous flu vaccines have used a very similar model, and the virus cannot make you sick. So it's a myth that the flu vaccine, as an analogy, will make you sick. Do people get a fever? Do they get chills? Do they get sweats and achiness after they get the flu vaccine? Sometimes, absolutely, but not because we're giving you the flu, but because your immune system's become activated and attacking the flu. And that means it's actually working. It's doing the job it should be doing. The same thing is true with the coronavirus, where your body actually is recognizing the little spiky protein that you see in all the images on TV of what the coronavirus looks like. Your body recognizes it after it's been tickled by the vaccine. And that allows your system to create antibodies for working against COVID-19 later. It's teaching your body basically how to respond if you become infected. It's as simple as that. It's not very complicated at all, actually. If you look at the mRNA vaccines, that's totally different. It works by introducing a piece of genetic code that tricks your body into producing COVID-19 antibodies. Not injecting a virus, not doing anything in the virus, just the code. So here's the problem. People are saying, oh my God, you're injecting DNA or RNA and so on. And I call it my myths of the vaccines. And myth number one, is anyone able to see these slides at this point? Because it would be very helpful. No?
Ahad and Amina are both trying to do it now. So
Okay.
one of them hopefully will be successful.
So myth number one is that the mRNA vaccines are changing your DNA. That's complete nonsense. It's not even possible. I'm going to tell you why. Because the vaccine doesn't go into the nucleus of the cell. You would have to go into the nucleus of the cell, which is where your genetic material, where your DNA is actually manufactured, in order, I think we're there. I just something pop up. So next slide. Go back. Go back. That's it. Exactly. Thank you. Nope. Next slide. Okay. So myth number one is that we're changing your DNA. We cannot change your DNA, even if we wanted to, because the vaccine elements are not going into the nucleus of the cell. The nucleus is the brain center of the cell. That's where your DNA is. And we can't change your DNA if we're not going into the nucleus. What happens is the mRNA vaccine basically breaks down, gets rid of the mRNA as soon as it unravels to basically tickle your system, to activate antibodies so that, again, it recognizes the virus if you're infected. Myth number 2 is that the vaccine can change your blood type. I can't change your blood type even if I wanted to. I'm an emergency guy. You come in with a massive bleed from a car accident, or somebody decided to do something nasty to you and you need a blood transfusion. I can only give you your blood type. I can't give you another blood type to change your blood because your body will react. And actually, that's what will kill you, not your injuries. There is exception to the rule, obviously. You always hear blood services advertising, we need O negative blood. That's the universal donor. But even when we give O negative blood to people, it doesn't change their blood type to O negative. They still stay as an A or a B or an AB or whatever. So myth number 2 about the mRNA vaccines is that basically it changes your blood type, which is not even possible. Next slide, please. Thank you, this is very helpful. Myth number 3 is that the mRNA vaccine is brand new. It's not new. mRNA vaccines have been around for more than a decade. It's been used in flu vaccines. It's been used in Zika. That was a nasty illness that was mainly seen in Brazil, but it worked its way up through South and Central America and even into parts of North America where there were very sadly deformed babies. It's been used in the rabies vaccine. It's been used in cytomegalovirus vaccine. So this is not something new. And that's, again, a lot of the mythology in and around the vaccines. What's really cool about the mRNA vaccines is that the future of vaccines is that you will only need perhaps one vaccine with multiple illnesses attached to it, so you won't have to get series of vaccines. So for example, a future mRNA vaccine may be not only for COVID, but it may also be COVID and flu. It may be COVID, flu, and the hepatitis A and B Twinrix that we recommend people use for travel, or Shingrix, which we recommend for shingles. So that's the future of mRNA vaccines, but this is not new. This has been around for a decade, and that's a lot of the mythology and scare tactics and so on. Next slide, please. Myth number 4 is that it's not FDA approved. Well, I find it actually quite curious, because why we as Canadians should even care if a drug is FDA approved. FDA is the American regulatory authority. Health Canada is the Canadian healthcare authority. There are many drugs that are approved in Canada that have never been approved by the FDA, and vice versa. There are drugs that are approved by the FDA that are never approved by Canada for a multiplicity of very complex reasons. And it's not uncommon to have one drug approved in one country, not another. But the fact is, by the way, they're all approved now by the FDA. The FDA has approved the vaccines, as has Health Canada, as you can see to the right of the slide. But the FDA not officially approving it, it was an emergency approval, is actually a legal definition, not a medical definition. There are legal requirements for full approval. All drugs get temporary approval before they get full approval. This was an emergency approval up until recently when it had been fully approved. So there's a lot of mythology around that. And then the next myth, of course, myth number 5, is that this was developed too fast, and therefore we really don't know anything about it. So I will address 2 points to that. Number 1, it was not developed too fast because we've been playing and tinkering with mRNA vaccines for more than a decade. That's number 1. Number 2, the development of any new drug, it's a process consisting of 3 phases: phase 1, phase 2, phase 3. And then the drug gets approved, licensed by the regulatory authority, in Canada's case, Health Canada. And then phase 4 is once the drug is on the market for ongoing monitoring of the safety of the drug. And if there's any, what we call signals that, hey, we missed something in the research phase, that we should go back and look. And that's happened in history for sure. Phase 1, 2, and 3, the biggest holdup in phase 1, 2, and 3 is not the science. It's not the effectiveness of the medication, or in this case, the vaccine. It's the fact that the people reviewing the files are sitting on 100 or more files each of new blood pressure pill, new antibiotic, new cholesterol pill, new cancer drugs. So their focus is all over the place. When the pandemic started, they realized they were going to have to be looking at potential vaccines. They were told to take all the other products off their desks, sweep them aside, and they had to focus all their energies, all their days just on the pandemic vaccines, and that's what sped it up. So what they did was they took out the bureaucracy, not the science, not the ethics of this, not the morality of this. They just took out the bureaucracy, which sped it up, and in a good way, obviously. Pregnancy and fertility risk. There's been a number of studies that have shown we now have literally tens of thousands of women around the world, including in Canada, who have given birth to very healthy babies after having been vaccinated. There's no evidence that it affects fertility. I actually spoke with a reproductive endocrinologist about 6-8 months ago, saying there's no science to say that it would cause any more risk to fertility risk than any other medication for that matter. And in fact, we know, and tragically, there have been cases where moms, while pregnant, have gotten coronavirus and passed it through the placenta to the baby, and both mom and baby have died. One of the most common things we hear, and I found it fascinating throughout the last election, which ended on Monday, was with the exception of medical contraindications, medical exemptions. And I did a ton of research on this, and I would ask my colleagues, and everyone kind of, I don't know. So what I did was I reached out to colleagues, and I'm staff at 2 teaching hospitals in Toronto. I reached out to colleagues in literally every single internal medicine specialty: neurology, cardiology, respirology, endocrinology, diabetes, thyroid disease, gastroenterology, rheumatology, people with rheumatoid diseases, oncology, cancer specialists, and so on. And I got an answer back from every single 100% of the physicians responded. And they all said that in their discipline, in other words, in cardiology, in respirology, et cetera, there are absolutely no contraindications. There are no exemptions for getting the vaccine, with 2 caveats. Caveat number 1, the patient has a known allergic reaction, serious allergic reaction to a previous ingredient from the vaccines. That would be legitimate, obviously. And in those cases, those patients should be admitted to the hospital to get their vaccine. I'm actually aware of one patient that had that done, and they were monitored overnight in the emergency room, and nothing happened, thankfully. And they went home the next morning, but they were there in the emergency in case something did happen, et cetera. The other condition was back from the cancer specialists, the transplant specialists, and the doctors who deal with patients with real autoimmune disease. When I say real autoimmune disease, I'm referring to people who are in active cancer care, who are on anti-rejection drugs for transplant, or patients are on what's called biologics, drugs for people with severe Crohn's disease, severe rheumatoid arthritis, et cetera, where their immune system has been downregulated. And in those conditions, the specialist said they're not contraindicated. What they need to do is speak to their specialist for best timing relative to their treatments of getting the vaccine. Because their immune system is downregulated. If you remember from my first part of this talk, it's your immune system that's doing all the work. We're just tickling it. What will happen is, because your immune system is downregulated from your chemotherapy or your radiation or your biological drug, then what happens is the timing of the vaccine is important, because you may end up with a blunted or a delayed response to the vaccine. So we want to time it perfectly relative to your chemotherapy, biologic, et cetera. But it's not a contraindication. The other contraindication would be someone who had a very serious reaction, obviously, to a first vaccine. And when I say serious reaction, I'm talking about anaphylaxis, where they could not breathe. I'm talking about those with myocarditis and pericarditis. I'm going to talk to those a little bit later, and so on, or massive stroke, of course. But those are really rare, and I'm going to show you some data how rare they are. The other one, which is as fascinating, is religious reasons. Now, I'm the farthest thing from anyone who knows about religion or to espouse religious philosophy or theology, but I did reach out to people who do know. And I said, can you please educate me? Share with me what I can do, what I can use for presentations. Next slide, please. What I found was that not a single major religion actually has a prohibition against vaccines. In fact, to the contrary, all the major religious leaders have supported vaccines. The Pope himself, because there were some questions about the vaccine, the AstraZeneca and J&J specifically. The cell line originated from an aborted fetus in the 1970s. So if that fetus was aborted or it was a miscarriage, no one's ever going to know. There's no way to know. It's back in the 1970s. That's number one. And number two, the Pope himself. And the Pope Emeritus, Pope Benedict, was still alive, but no longer the Pope, basically said, this is life-saving. You have an ethical obligation. And refusal to have the vaccine is suicidal. Furthermore, it is an ethical choice because you're not only playing with your health and life, but you're also playing with the lives and health of others. Quote unquote, I have signed up, one must do it. And mRNA technology is not new. Next slide, please. Jewish leaders, Muslim leaders have said one has both a religious and moral obligation to protect their families and their neighbors. Many of my colleagues and others have said, well, Jehovah's Witnesses would not get it. I reached out and I did my research and found out that Jehovah's Witnesses have removed vaccine prohibitions in the 1950s. Mormons have no religious prohibition. Every major religion has basically not created a prohibition from getting vaccines. So the medical exemptions and the religious exemptions seem to be losing the strength of their arguments of those who are anti-vaccine. Today, the most common form of COVID out there is the Delta variant. And here's the crazy news. 90% of Canadians and Americans, our closest neighbors, that's why I included them, are unvaccinated or partially vaccinated. Those in the hospital, that's awful. Look at Iceland, 90% of their population is fully vaccinated. And as of last week, they only have 10 patients in the hospital. I mean, there's a statistic that you just have to, you can't ignore it and so on. The Delta strain is the most common strain today. Next week, it's going to be the Lambda. It's going to be something else, something else. Don't be frightened by that. All viruses mutate every year and create multiple strains. They are living organism viruses, no different than you and I are a living organism, and it's survival of the fittest. They're basically constantly morphing, constantly mutating, constantly creating different variants to stay alive. The good news is that basically we're able to nip them in the butt, and it's not common that the other ones are going to be more virulent than the Delta is now. Could it happen? Absolutely. I don't have a crystal ball to be able to say that it's going to happen or not going to happen, but at least we know we're able to nip it in the butt. Mixing vaccines, there's 3 studies, a British study, a German study, and a Spanish study that showed that not only is mixing and matching completely safe, it actually is likely more effective than just sticking to one class, two AstraZeneca or 2 mRNA, Moderna or Pfizer. There are other challenges, practical challenges with that, we'll address a little bit later, but basically mixing and matching is completely safe and in all likelihood more effective. And in that regard, Canada turns out to be, our Canadian experiment, we call it, turned out to be the right thing to do. Having COVID in the past does not protect you. That is a myth. Why is it a myth? Because likely the COVID that you had 6 months, 8 months, a year ago was not the Delta variant, and the Delta variant is the predominant variant, and the Delta variant is much more virulent. But the latest studies have shown, as literally as last Friday released, is that a combination of having COVID and the vaccine protects you, and rather than just getting the vaccine alone or having COVID alone, and so on. But certainly, it doesn't completely protect you. Third doses, is this a booster or is it another dose? Latest data suggests, and I attended an all-day meeting last Friday, that the third dose is not a booster, but rather a completion of a series. Very much like the Twinrix, the hepatitis A and B, is 3 shots. Very much like Shingrix, the shingles vaccine, is 2 shots. We don't call shot number 2 and shot number 3 boosters. In all likelihood, you're going to need the third one in order to get the maximal effect. Third doses are here. They're here for our immune compromised. Our long-term care residents are already getting it. And each year we develop a new flu vaccine, and we take all the existing previous strains and we tap on the newest strains to them to make them more effective. Quebec and Saskatchewan are the only provinces to date, I'm sure the others will follow, creating a third vaccine for travelers, because for some reason, some countries will not recognize mix and matching, and some of the cruise lines, if you're going on a cruise, will also not recognize mix and matching, and therefore they're offering a third vaccine so that you're not precluded from traveling to those countries or going on a cruise. All the levels of government have basically are enforcing vaccines, the vaccine passport. Every province has jumped on board, all healthcare facilities. I'm quite surprised, but I'm quite thrilled that universities jumped on quite early, and the school boards are jumping on board as they should be. Next slide, please. Crystal ball, employees tell me every day, literally every single day, patient says to me, I want to come back to work. I'm eager to come back to work, but I need to know the guy sitting next to me is fully vaccinated because I don't want to bring anything home. I don't want to get my spouse, my children. I live with my elderly parents, or I have contact with my elderly parents, or I'm responsible for my elderly parents. I don't want to bring anything home. And don't we as have a responsibility to take care of our employees and take care of each other in that regard? So more and more companies are adopting vaccine requirements. I've been working with quite a number of them. And more companies are adopting testing of unvaccinated. Initially, and I don't want to get into the legalities because this is certainly Mike's area and I have no expertise. I don't like to go into areas I know nothing about, is that whether the employee pays or the employer pays. But what I'm hearing from my clients is that we are willing to pay up until a certain time, but we're not paying in perpetuity. This is going to be too costly. And if you don't want to be vaccinated, that's your choice. Bioethicists, constitutional experts, labor law experts are becoming very clear in their messaging. This is a public health and moral imperative. There's no provincial or federal prohibition. We heard this right from the beginning. Oh, it's against the law. There's no such laws that say that, and I'll stay out of Mike's space. In fact, there's lots of Canadian precedent: smallpox, polio, hepatitis, etc. And the Human Rights Code allows for limited infringement for the greater good. I could not think of a greater good than coronavirus. But I want to say everyone's worried about privacy, as I am as well, about my patients. I have an obligation and to protect my patients' confidentiality. Have you been to a restaurant recently where you use a QR code? They ask a lot of very intrusive questions: your name, your phone number, your email. They ask you all these symptoms. The vaccine passport says one of your colleagues in the call we just said a few minutes ago is just going to have a tick mark, and all they're going to have is your name. The back end is going to be your name, your OHIP number, and you're vaccinated or not vaccinated. So there really is no infringement on your privacy or databasing. I have no idea where the restaurant's database is, but they're asking me all these questions when I go out for pizza and wings. Good news, bad news, real news. The bad news is COVID's not going away, guys. The flu has been around for 100 years. COVID will be around hopefully for a lot less, but we don't know. And we basically, it's here. The good news is an incredibly effective treatment has been developed, and it basically is saving lives and preventing death. And the real news is we're going to learn to live with this and learn to function. We already have, we already are. We're very resilient as a society, but we can only take so much. Next slide, please. So the gold medal is no hospitalizations, no ICU admissions, no deaths. Every single year, sadly, before COVID, several thousand people die of influenza. They will continue to die of influenza. And I'm not trying to be dismissive or flip it. And people will continue to die of COVID. But we have a means to protect people and help people in the best way we can. Next slide, please. So a guy named Edward Jenner in 1749 invented the very first vaccine ever for smallpox. Smallpox killed 300 million people. That's 10 Canadas. And an article I read literally last weekend, the single greatest life-saving invention in medicine of all time, more so than penicillin, more so, can we go back? Sorry, we just lost my slides. More so than any other medical invention. On the other hand, Andrew Wakefield, the founder of the anti-vaccine movement, a physician, had his medical license revoked for falsifying high-knowledge research data. It was complete fraud. He was also convicted for fraud because he made $43 million on profits from selling an autism kit. Remember, this is the guy who goes around and has told everybody, the anti-vaccine movement, that vaccine cause autism. There's not one stitch of evidence to prove that. And furthermore, his test kit that he invented and made $43 million tests for autism. And in fact, the studies have shown there is no test for autism, and we all know that. Next slide. Reality check. As of 2 days ago, 6 billion doses have been given globally, 2.5 billion fully vaccinated people, 55 million doses in Canada, 26 million fully vaccinated Canadians. We prevented 140,000 deaths in 5 months and 3 million new cases of COVID in 5 months. There is the take-home message. That is a home run in every definition of a home run. Next slide, please. I'm coming to the end. No medicines are 100% safe. It would be disingenuous and dishonest of me to say that everything is 100% safe. We don't know everything. We've learned a ton. We're learning a ton. But here you go. On 50 million doses, this is Canadian data, not global data, 0.028% of the population have had an adverse event, and only 0.008% of those patients have had a severe adverse event. What are these events? So everyone talks about myocarditis and pericarditis. So myocarditis is infection of the heart muscle, the myocardium. Pericarditis, infection of the sac around the heart, the saran wrap that wraps the heart. I've had pericarditis twice in my lifetime, many years ago. Viral infection. I didn't end up being hospitalized. I ended up in the ICU, and I'm here to tell the story. There are 3.1 million new cases of myocarditis and pericarditis every year in Canada, long before anybody ever heard of COVID. If you want to use the rule of tens, I couldn't find the exact number for Canada. Let's say that's 300,000. If it's 10%, if you want to do 1%, it's 30,000 cases. There were 716 cases of myocarditis or pericarditis related to the vaccines. Not zero, for sure not, but infinitesimally small. 15 cases of cerebral venous thrombosis, a very rare phenomenon outside of this situation with AstraZeneca. I've never seen one in my 30 years of practice. Guillain-Barré is a neurological condition, 76 cases possibly related to the vaccines. Let's say probably. Let's give it the benefit or the negative of the doubt. Typically, without vaccines, we have between 370 and 850 cases of Guillain-Barré a year in Canada, unrelated to COVID. And the real win, I heard a bioethicist last month speak, and it was a brilliant talk. Why are we constantly spinning a negative on the vaccines? Why aren't we making this a positive? Vaccines empower you to become secured physically, physical health and mental health. It opens up the doors for you to go travel again, to go watch the Leafs, the Raptors, or the Blue Jays play, go to restaurants as you like, go to movies, a sense of normalcy that we desperately need and want, and change the I can't do it to I can do it. And that's my presentation. I welcome any and all questions from the audience.
Thanks, Dr. Wasser. We do have a couple questions. The first one is, if having COVID does not protect you, or having previous infection does not protect you, why is the Ontario COVID-19 workplace and employee screening making exceptions, i.e. the same exception as fully vaccinated? So if you've had COVID-19 in the last 90 days, that's part of the screening tool.
So certainly if you've had a COVID-19 within the last month or so, your antibodies are at the highest level they ever will be, and then they'll wane over time. And that's true with vaccines as well, by the way. And therefore, you're most protected during that window. But after that, your immunity drops and drops and drops. For people who had it earlier, they did not have the early year plus. We did not have any Delta variant. Delta variant didn't exist. So those people are completely unprotected from the Delta variant, Lambda variant, or whatever variants pop up on the street tomorrow or next month. So that's where that protection comes from early on after you've had an acute illness, but that basically will go away over time. We haven't seen the herd immunity that we see in other viruses with COVID yet. And just to let you know, herd immunity, everyone loves to talk about, there's natural herd immunity and the vaccines impose herd immunity, and of course the combination of the two. Natural herd immunity is different in every disease. Herd immunity in measles is different than mumps, is different than chickenpox, is different than COVID. So we can't say, oh, what percentage of the population have to have it to have herd immunity? We have decades of experience with mumps, measles, rubella, chickenpox. We do not have that experience with COVID. And that's why the number keeps moving from 70% vaccinated combination with natural immunity creating herd immunity. And now we've jumped to 90% because we have not seen it with 70%. If you look at countries that were really aggressive early in vaccination, Israel, Bahrain, others, they hit 70% plus vaccination and they did not hit herd immunity. And that's why the bar keeps moving. So look, we're learning every day, obviously, about the virus. It's relatively new in society. It's only a year and a half that we've experienced this. I hope that answered the question.
Yes, I believe it did. There's another question. Employees are willing and want to return to work, but only if they can verify the person sitting next to them is vaccinated and safe. But can't vaccinated individuals catch, carry, and transfer the virus as well?
So the answer is yes, yes, and yes. Vaccinated individuals can catch, can carry, and can transmit the illness. But here's the difference. We have almost no hospitalizations of vaccinated people. So again, I don't want to sound flippant or dismissive. I actually don't care if I get COVID. In fact, if I get COVID, I'm actually offering myself additional immunity to the 2 vaccines that I've had, or a third someday whenever I get that. So what I'm preventing you from getting is the hospitalization, the ICU. COVID, we're not getting rid of COVID. We're still going to have it. We're just not going to get very sick from it.
Okay, you froze a bit, but I think we got the gist of that. There were a couple questions earlier during the webinar about boosters. Any idea on, and I know some of them are already available for people who are immunocompromised or have certain conditions. Any idea on boosters for like everyone across the board on when those could
I don't have any insight, but I'll be very honest with you. The data shows waiting 6 to 8 months. 8 months is the magic number being used now by the Israelis and in Bahrain, the 2 countries with the greatest experience of longevity of vaccine. There is chatter about 6 to 8 months. So people should think that way. But the longer you wait, the better, by the way, in the 6 to 8 month period. And the longer you wait, the better, because the developers are actually tweaking the vaccine to account specifically the Delta variant. Remember, the original vaccine did not account for Delta because Delta did not exist, right? Now we know Delta exists. So it does downregulate Delta because it has a broad spectrum, but it's not specifically targeting Delta. So here's the example. Every year the flu vaccine comes out with the old variants and the new variants from Asia. That's how we invent the vaccine, because we know what's going on in Asia 6 months before. And sometimes we miss them. We miss them, so we get more flu that year. But we don't get as many sick people being hospitalized because it still is able to tickle even the variants we didn't actually specifically target to some extent. So it does have an effect. But if you wait longer, the effect is greater.
And then we have a couple more questions. So there's a decent amount of health and safety and HR professionals on the call. And if they're not already, they're going to be required to talk to workers who may be vaccine hesitant. Do you have any advice to them in terms of how these conversations should go, or what they could be saying to these employees who are vaccine hesitant?
Yeah, so if they're vaccine hesitant because they're worried about, unfortunately, we've never seen this degree of misinformation and disinformation. A study done about 2 months ago showed that all the misinformation and disinformation, or the mythology of the vaccines, actually emanate from 6 anti-vaxxers around the world. Well-known, prolific social media people and anti-vaxxers. 6 people have caused this mess with regard to all this mythology. So I tell people, don't go on social media. Don't go to Facebook or Dr. Google. Go to reputable sites. If you want to stick to Canada, because we're Canadian, you trust Canadian data, go to UHN, University Health Network. Go to McGill's website, McGill University website. If you're trusting of American websites, the Mayo Clinic, the Cleveland Clinic, Harvard, brand name places to go to with lots of information. Unfortunately, there's a lot of self-proclaimed experts in the area, and even physicians. There's one guy who's prolific, and people reference him all the time when they meet with me. They go, "This guy's from the Mayo Clinic." So I'm not dumb. I do my research. I go in, I dig in. Cleveland Clinic, sorry, not Cleveland, the Mayo Clinic. The Mayo Clinic has completely disavowed any connection or relationship with this person. He never trained there. He did 1 month rotation during his training. That does not make him a Mayo Clinic doctor. They would even accept a guy like me to do a month rotation at Mayo Clinic if I asked them when I was training. He actually is in Idaho, not the epicenter of science and brilliance in the world, I can assure you. And the Idaho Board of Medical Licensure is taking away his license. It's in the middle of the hearings. This guy claims to be a Mayo Clinic expert and co-developed the mRNA vaccine. Complete mythology, a complete lie. And the problem is people are looking at all this nonsense. So tell people when they ask, if you don't want to believe me, you don't want to believe your employer that's saying this is good for everybody, go to reputable websites. People who are not, who have a personal interest. The university centers have no interest. They have no benefit financially or any other means to advocate for something other than it's good medicine and good science and good for the public. I hope that helps.
Thank you. And then there's a question on vaccines for kids. Any idea on when Health Canada will approve vaccines for kids?
Great question.
5 to 11?
So Friday, I was told that the FDA is literally this close to approving ages 5 to 11, so over 4. The Israelis have done a large study. The Europeans are doing a large study. So it's coming. Look, nobody ever wants to make a mistake on anybody, but certainly not on children. We pay a high price tag on our children. I'm a father as well. We would never want to make that mistake. So we started the older and we worked our way backwards. And we now know it's incredibly safe on our teenage kids. And the clock is moving back. So Canada is looking at the data. I don't know what the timeline. I don't work for Health Canada, and they're very secretive, as they should be. They don't want to slip anything out in advance. But I do know it's an active process, and the Americans are about to approve age 5 to 11.
And then there's another question on back to boosters. Will it be like a continuous booster, like similar to the tetanus shot, where you get it every? Or will it be more like the flu shot where you're supposed to get it every year?
So I'm not a vaccine developer or virologist, but in the talk I was at last Friday, which considered an international group, by the way, of experts and one of the leading vaccine researchers in America from an academic institution, not from a pharmaceutical company. She said that basically this is going to likely be for the next X number of years. It's going to be like an annual or twice a year booster. Once we get the final, once we figure it out, is it 2 doses or 3 doses of the primary series, we call it, and then there'll be boosters. And she predicted once or twice a year, like the flu shot, more so than a tetanus, which is every 10 years. Particularly speaking to a group of people in construction, and I hope you're all updated in your tetanus. Tetanus is alive and well in Canada, and you don't get tetanus from rusty nails. That's a myth. You get tetanus from cuts that are contaminated with fecal contaminants from rats and mice and birds and flies that poop on it. So it won't be 10 years. It will maybe be once a year or twice a year. It's still part of the learning curve.
Perfect. And then the last question. Someone asked, I noticed your data on the vaccine, but I'm wondering what the rate of recovery is if you get COVID. If the rate of recovery is higher than those numbers of the side effects, what is the actual benefit? So I'm not entirely sure what the question is. What is the benefit of, I assume it's what's the benefit
I think I
of
know where
getting the
this question's
vaccine?
going. The person asking the question, please be, I welcome clarification. People say the disease is not worse than the vaccine. But we don't know that, right? So the amount of people that have serious reactions is infinitesimally small. I'm talking about serious to end up in a hospital from the vaccine, serious enough to give you a massive cardiac event or stroke and so on. Those numbers are infinitesimally small. Even the case of myocarditis, which are very common, as I showed you, how many people get myocarditis and pericarditis a year is very high. Very few of those people ever end up in the hospital or ever end up really sick. I had pericarditis, they said, twice, and it was uncomfortable, I can assure you. I had chest pain, shortness of breath, walking up a flight of stairs, but it went away, and I'm here to tell the story, and I'm an active person, no long-term consequence. And that's saying what we're seeing with the pericarditis and myocarditis from the vaccines. So the question is the illness worse than the vaccine or the vaccine worse than the illness? I can predict what the response to the vaccine is going to be. I can't predict what the response to the illness is going to be. And while the vast majority recover from COVID uneventfully, those who are quite sick are terribly sick. A gentleman, 38 years old, basically came in unable to breathe. Here's a healthy, fit guy, father of 2 young kids about to start school, and he could not breathe. His oxygen saturation was like 80 in normal oxygen saturation. Right now, we're all floating in the area of 97 to 100%. We get worried about you when you start hitting the low 90s, and he was like barely 80, and literally thought he'd never see his spouse or his kids again. That's a serious disease, and I can't predict if you're going to get serious COVID or not serious COVID. We had a death yesterday in the West. I don't know if you saw that. In the 20s, someone died. People die from this disease. And I do believe we have a greater public moral responsibility. Our hospitals have already been feeling stress fractures for years. Our hospitals are collapsing under their own weight. And sadly, our nurses are quitting in droves because they're overwhelmed. They're burnt out. And we have doctors who are burning out as well. So it's not just about you getting the illness. We do have a moral responsibility to each other as a society. And I'm not trying to be higher than now. This is reality. Our hospitals were on the brink of collapse last spring, and Alberta, right now, their hospitals are collapsing.
Thanks, Dr. Wasser. I think that's all the time we have for today, but I truly enjoyed the myth busting. I think it's super helpful to our members and the attendees here today. So thank you.
Thank you very much. And thank you, Andrew, for reaching out to me. I really appreciate it. Have a good day, everyone. Be safe. And Andrew, I welcome other questions offline if your membership would like more things clarified or answered if I wasn't clear or didn't answer something they really wanted to address. Okay.
Much appreciated. Thank you.
Everybody stay safe and get shot.
And I'll kick it back to Andrew for some closing remarks.
Yeah, thank you to all the speakers, including Dr. Wasser.